Welcome to the podcast where we discuss health, health span, lifespan, and longevity. I'm Dr. Noorgajraj. Welcome to the podcast. My name is Dr. Noorgajraj. We have a very special guest today, Professor Shailendra Patel. I first met Professor Patel about 40 years ago. We were residents in England. He is currently Professor of Endocrinology at the University of Cincinnati. He attended the prestigious Oxford University in England. After completing his medical training, he moved to the United States and completed a fellowship in endocrinology. He is a world-renowned expert in lipid metabolism. So thanks, Professor Patel. I want to congratulate you on your latest paper published in Endocrine Practice. It's entitled American Association of Clinical Endocrinology Clinical Practice Guideline on Pharmacologic Management of Adults with Dyslipidemia. Professor Patel is the lead author, and he's the chairman on this task force. So thanks very much for talking to us about this very important subject. So first of all, perhaps you can tell us about your publication, what it entails, what you found, and you came out with 13 evidence-based recommendations. So over to you.
Thank you very much for inviting me. And Noor, it is such a pleasure to see you again after so many years. And for your audience, let me say that Noor was my senior when we were together, and we absolutely had a ball because he not only mentored me in the early parts of my medical training, but he was a wonderful friend, and we just absolutely had a ball. With respect to this paper, so I'm a lipidologist and work on heart disease. I'm also an endocrinologist, so clearly things like diabetes, hypertension, investigating any of the endocrine disorders are part of my background. ACE, which is the professional organization for clinical endocrinologists, have been putting out guidelines for various topics that are pertinent to endocrine. And one of them is obviously how do you manage lipids? And the word dyslipidemia is used as an indication of where the lipid panel is a little abnormal or needs management for other reasons. So the word dys is just that. It's saying what we think is that needs a little attention. And this lipid guideline that we came out with our task force, and I have to thank all of the members of those people who worked very, very hard to do this evidence-based management, is to come up with an update for the newest medications that have come up, looking at the previous medications and their evidence to say, are we still doing right by what we're doing? And can we do better? And so this update is really to make sure that we've caught up with the sciences, mainly because each of the national guidelines that they come out with, lipid guidelines, they do them every 4 or 5 or 6 or 7 years. And so we had a little hiatus in between where we said, we've got all these changes, but we need a little update. So that's the reason why this task force was put up. And we addressed the newer medications, and it is about talking about lipids. So I guess before the show, you and I were talking, and you were saying, well, what is the deal with lipids? And I think that you were saying, well, what is this concept of good cholesterol and bad cholesterol? Did I get that right, Noor?
Correct.
Okay. So let's start with the whole history first, so it makes it easy for everyone to understand. We know that certainly in the US and in Europe, the biggest cause of premature death in these countries is heart disease. And the vast bulk of the heart disease death and morbidity are from atherosclerotic disease. And the risk factors for developing atherosclerosis, right, hardening of your arteries, as we used to in old days call it, right, is the deposition of these lipid-laden plaques that develop in your arteries. And if they block the coronary arteries off, you're going to get coronary artery disease, myocardial infarction, heart attacks, and then heart failure as a result of the damage to the muscle. If they are in the circulation to your head, obviously you're going to have issues with stroke. And
Yeah.
if they have damage to your legs, you're going to have peripheral vascular disease. And the risk factors for this are always got the classical ones, right? Do you have a high cholesterol? Do you have a high blood pressure? Do you have diabetes? Do you smoke? Are you sedentary? Are you eating right? Is your diet bad? Do you have stress in your life? These are the things that are classical. Obviously, there's a difference between males and females in terms of the males getting predisposition a lot earlier. So there's this gender difference. And of course, family history comes in, which is really pertinent to genetics. That, if you have a family history of premature atherosclerosis, then you're going to inherit some of the genes and some of the background and some of the lifestyles that predispose you to it. So it's a complex, multifactorial thing. And the lipids are one aspect. That's it. So I want to make sure that your audience understands that this is one aspect of many things. But the lipids are important because it turns out that when people started looking at risk factors and what you can modify, right? So things you can modify, things you can't modify. You can't modify your hardwired genetics, right? You inherit them, you really can't change them, at least for now. But you can do something about something that can be modifiable. So let's talk about blood pressure and heart disease. This postcard is about lipids, so we're not going to talk about blood pressure, but we can talk about lipids. What are lipids? So I always tell my patients, all of you know that if I gave you a glass of water and a glass of oil, and I say mix them, they're going to say, Dr. Patel, oil and water don't mix. Well, lipids are oil, but clearly we do get them mixed in our blood.
Yeah.
And the way that that happens is that your body puts them into these particles called lipoproteins. And the way I explain that to people is to say, okay, if you have a glass of oil and a glass of water and you want to mix it, if you're a good cook, you're going to break an egg, take the egg yolk, put the egg yolk into the water and add the oil and whisk it. And lo and behold, all of a sudden, everything is mixed into one single thing. I mean, that's the basis for mayonnaise, of course.
Right.
But you can see that the cholesterol in the egg yolk took the oil and the water and put it all together.
Right.
That's actually a kind of biological way of what your body's doing.
Mm-hmm.
It is taking the oil from your diet, and your body makes oil too, of course, and it is packaging it into these mayonnaise-like particles, tiny ones that float around in your blood. And of course, if they're floating around, you need to be able to keep them under control. You don't want too many of them. You want to be able to circulate and get the oil, which is nutrients, which is energy, to all the parts that need to burn it for energy, and take it away so that you can keep it at a low level. So that's really a very simple way of understanding what lipids do. And if you have a lot of these particles, then they can be susceptible to damage. Smoking will damage the particles. The particles are then binding to your endothelium in your blood vessels, and all of a sudden the macrophages come in to clean it up. But if you put a lot of trash into there, just like any trash, it's going to build up as a dump. And that's what atherosclerosis in some layman's terms is, right? So these lipids are important. We see them, it's a risk factor. And we have a huge science base that says that if your cholesterol levels measured by the lab is increasing on a population level, your chances of getting increased cardiovascular disease in that population rises. And then people said, well, if it's rising because of high cholesterol, can we bring it down? And the first set of evidence many, many, many years ago showed that if you lowered the cholesterol, you actually lowered the heart disease risk. And at an individual level, people who had had a heart attack, who then went on drugs to lower their cholesterol, they found that those people didn't suffer the second heart attack or die early from heart disease compared to people who didn't have their cholesterol level. And that's really the whole revolution of when these statin drugs came out, right? So statins are these drugs that allow your body to lower the LDL cholesterol.
Right.
Now, people at that time wanted to tell everybody in the world to pay attention to cholesterol. So it became a public health way of saying, we need to get you more educated about cholesterol. And so this concept of good and bad cholesterol came from that. It's a terrible terminology. It had a place because they wanted to make sure that the public were made aware. But I think it has got us into trouble now. So let's clarify it. When people were looking at which parts of these lipoproteins in your blood were good or bad in terms of risk, they found that if your LDL cholesterol went up, your risk of heart disease went up. But if you had a higher level of HDL cholesterol, right, your risk was actually lower.
Right.
So they wanted people to say, we want you to lower your LDL cholesterol, but increase your HDL cholesterol.
Mhm.
And that's where the concept of good and bad came along. So
Right.
people could sort of understand their lipid panel when the doctor did it.
Right.
The problem was that there is no such thing as good and bad in medicine. There really isn't. I mean, medicine is not about good and bad. It's
Right.
just stuff that happens from science. So that concept should be got rid of, and people should not be using this anymore. And I hate to say it, but we should not be discussing it in those terms either. The lowering the LDL has now been shown in many, 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 many epidemiological, interventional, randomized double-blind control studies to show that if you lower it, you absolutely make an impact on your future cardiovascular risk.
Right.
Interestingly, there's really been very little evidence to show that if you actively go out of your way to raise your HDL, the good cholesterol that people were talking about, that it impacts the future risk of cardiovascular disease. So, in a way, while our previous scientists were keen on talking about it, the subsequent evidence to try and do it the way we are doing it has not been shown to be a place where we can intervene to make a difference. So we should probably now get away from talking about raising HDL anymore, but we should certainly still focus on lowering LDL cholesterol, right?
Yeah.
And I want to point out something that always gets confused, and I want to be more scientific and less layman-like. It's not cholesterol that you have to worry about. It's the LDL particle, right? The thing that is the mayonnaise. Don't focus on the content as much, although there is some science about the content, and I don't want to get too esoteric and be a little bit too scientific about it. Otherwise, people will say, "Why, goodness, you really did have a professor on your podcast here." But it's the particles. And prior to us coming online, I think that you'd sent me one question about something called ApoB or apolipoprotein B. And so this is a good segue into my telling you about LDL cholesterol particles. So the LDL cholesterol particle just happens to be that particle that has a lot of cholesterol in it. Hence, it's called the LDL cholesterol particle. But it only has one protein, literally only one protein. It's a very big protein. It's almost like a little belt that it forms around the particle, which is spherical. And that protein is called apolipoprotein B. The terminology of these apoproteins came from when they were first discovered. And instead of naming it in a certain way, they named it using the alphabet. So they started with apolipoprotein A, apolipoprotein B, apolipoprotein C, apolipoprotein E, etc. You get the idea.
Yeah.
At that time, science was not quite so advanced, but it was an advance. And so the naming is stuck, and so it happens to be ApoB, and we shorten it to ApoB. And so if you measure ApoB in your blood, because the LDL particle only has one ApoB on it,
Mhm.
you measure the number of LDL particles.
Mhm.
And obviously, it's the number of particles. If you have a lot floating around in your blood, the chances that they will deposit in the wrong place is increased compared to if you have less. So you see, the concept still works,
Right.
right? So that's where the ApoB comes in. Now, coming back to our paper, and although I am personally disappointed because my science was about apolipoprotein B, I was disappointed to find out that the standard 10-cent test that your physician does for you, which is your lipid panel, which
Mhm.
measures the total cholesterol, the triglycerides, gives you the LDL cholesterol measurement, and gives you the HDL cholesterol measurement, was just as good. And measuring the ApoB for general purposes did not add more information to risk stratifying you, right? So this paper gives an update to say, should we really be adding ApoB to the lipid panel to make it better? Now, I'm disappointed because obviously I told you that it counts the particle size itself. But it turns out that our science is so advanced that we kind of know that for most people, so remember there are nuances, it doesn't always apply to everybody 100% of the time. But for more than 95% of the people, adding the ApoB will not change your future risk profile. So you probably don't need to do it except in limited circumstances. And this podcast is probably not the right place to discuss the nuances here. But yeah, it has a role, but I don't think you need to put it into routine use right now.
Okay.
All right. So I'll take a breath and make sure that I've covered everything, but I'm just going to quickly summarize. Lipids are important because they're a major risk factor for future heart disease or even existing heart disease. Treating them, there's a huge amount of science. There are different kinds of drugs, and we can talk about the updates on those in a minute. And then this concept of good and bad should be thrown out, but we should certainly focus on the particles themselves. We want to make sure that we understand the particles. And diet has a major role in how your cholesterol is controlled. And then obviously the drugs come in because you have genetics that give you a background. And clearly, if you can't alter your lifestyle too much, then you're going to need to have pharmacotherapy to try and help you prevent future ASC deviants. And I'm going to tell you that even now, right now in the US, the number one cause of premature death in men is clearly heart disease. And for the women out there, the number one cause of premature death is not breast cancer. It's actually still heart disease. Breast cancer is number two, but heart disease is still number one.
Well, before you move on, what about ApoA? Where does that come into it?
Right. So there are two kinds of ApoA, and I want to make sure that we get them right. So there is Apo capital A, right, which is the particle that is present on the HDL particles. We are not talking about that because in clinical practice, no provider is ordering an Apo capital A particle or measurement. But what you are talking about, Noor, I think, that clinicians do order is Apo little a.
Yeah.
So the way we terminology is that it's actually Apo with brackets, lowercase a, close brackets, right? And Apo little a is a protein made by the liver. It is strongly genetically controlled, and it comes in many, many versions. So the ApoA structure is that it's like, so the word people have used is a kringle, Kringle. Kringle comes from this kind of, and I forget whether it's a Danish pastry or a Swedish pastry
Right.
or even a hairdo, but it's like a structure. And your body, your genetics, your genes, they can have these repeats that encode the kringle. So an ApoA can have 1, 5, 10, 100, maybe even 200 repeats of these kringle or whatever number there is because it's based on your genetics. And based on that, your ApoA measurement in your blood is going to be based on the number of repeats you have. So that's inherited. Now, it's not the ApoA that's coming out, but what's happening is that ApoA is then covalently stuck on your LDL cholesterol, right? So LDL cholesterol, I told you, has only one of these big proteins called ApoB. But the ApoA in your liver is then attached to that ApoB. And when that LDL cholesterol or the VLDL cholesterol comes out of the liver, it has this LPA. Now, LPA is spelled capital L, lowercase p, brackets, lowercase a, close brackets, LPA. And that's what your primary care or your cardiologist or your endocrinologist is going to measure. And why would they measure it? So if they want to know whether you have risk factors, there are many risk factors that we can measure. Some that we can ask about, some that we can measure. We can see whether you're a male or a female. We can see your age, because clearly age is important. We ask you about your family history. We can measure your blood pressure. We can see whether you have diabetes. We can measure your lipids, LDL cholesterol being one of them. We can measure your LP little a because in epidemiological studies, it was shown primarily in white Caucasian populations that the increase in the LPA predicted the future risk of ASCVD events, atherosclerotic cardiovascular events. All right.
Right.
So that's the reason why they measure it. But remember that you can use other risk stratification. So in our paper, we looked at whether measuring the ApoB was important, whether measuring coronary artery calcium was important, whether we should be looking at vascular monitoring that might help as well for predicting future cardiovascular risk, right? And LP little a is one of them. Right now, as we are doing this podcast, there is no FDA approved medication that has been shown to alter your level of LP little a in the blood. So while people may be able to measure it, there is not an effective way to lower it to then see whether it changes your future cardiovascular risk. Sometimes when I have this conversation with patients, I talk to them about the fact that we can tell you that you have Alzheimer's disease, right? But we don't have drugs to improve it,
Yep.
right? And prevent it. So it's in the same category. We can tell you about your risk now because now there are tests of talking about Alzheimer's diseases, right? That tells you whether you're at high risk. But intervening on these actions to then say, I can make a difference does not exist, right? So that's where the LP little a comes in. It's a risk stratification step, but it is not something that you can intervene on. Does that clarify that?
Yes, that makes perfect sense. So if you look at myself, for instance, I've got high cholesterol. I'm on a statin. I'm also on aspirin. Would there be any advantage or any change in management if I had my lipo-B tested? Or the other question, anybody listening to this, they're thinking, well, maybe I should get my lipo-B done. I know you didn't want
LP
to get
little a,
into
you
this
mean?
too
LP
much.
little a.
Yes,
You
sorry.
mean LP little a? LP little a, yes?
Yes. So, I mean, who
Yes.
needs that? You said 95% don't need that
Yeah.
additional testing, but
So
just very briefly, who are the
yeah, so
5%?
this question is always a very important one, Noor. Um, who should get testing and how much and why? So if you just let's start with risk stratification. In a way, it's like saying it's like insurance. Who's at risk and how much? Because you clearly in the healthcare system need to target the people who are at the highest risk and then you will come down to people who are at the lowest risk. So risk stratification is important. Otherwise, we will end up treating everybody in an aggressive manner, and not everybody will get benefit. And sometimes you may even get drug side effects, for example, when
Right.
we overdo it, right? So risk stratification is important. So if someone comes in for the first time into my clinic, the first thing I ask is, are they what we call primary prevention, i.e., they've got nothing wrong with them, but we need to know whether that we can predict whether there might be something wrong with them in the future, or they've already come in because they said my cardiologist had to put some stents in me. They tell me to go see my endocrinologist or my primary care to say, do I need things changing, right? So we use these risk factors to stratify. So when you first come in, we're going to check your blood pressure. We're going to get some labs done. We're going to measure stuff and ask the question, do you need extended risk factor calculation? If you turned out that you already have a low risk, and by the way, there are about 6 or 7 different risk calculators out there now. The American Heart Association just came out with an updated one recently, available to everybody, and it's available online, that says put in these parameters and we'll tell you what's your future risk of developing an atherosclerotic related event in 10 years or 20 years is this number, right? So I think that the first thing is use it to risk stratify. Talking about you personally, okay, you're on a statin. All right, so the decision that you and your primary care or whoever made a while back is to say, we looked at you, you've got a risk, we put you on therapy. Once you put you on therapy, then you want to ask whether one, is it at an effective level? And that's all you need to do. Because trying to further risk stratify is only if you are having issues with clinical atherosclerotic disease. Because if you're not and you're treated at goal, trying to then look for more reasons, you don't need to because you're already on therapy.
Right.
You just want to make sure that your therapy is effective. So hopefully you're being monitored for that,
Right.
right? But the risk factors come in when you want to ask the question, should I go on a medication or not?
Right.
Because the one thing that we have not addressed, and that prompts me to be more aggressive about telling your readers is, well, before we get to using pharmaceutical agents, we really want to make sure that you've addressed your lifestyle. The lifestyle is the base, absolute base of how you need to be changing it. So the moment you even walk into a doctor's office, you really should be prepared to say, tell me what the ways I can change my lifestyle, to change my diet, to change my sedentary profile, to help improve all the things before we talk about drugs,
Right.
right? Because drugs cannot fix a bad lifestyle. In fact, you can out eat most of my drugs.
Right. Yeah.
So it's very, very important. So if you start with that premise, then yeah, if you're having issues, I think that you could certainly look for other reasons to get intensive.
Hmm.
So in your particular case, unless you have an issue, I don't know that I would necessarily go out of my way to give you an LP-little-a test, unless you say, yeah, my cardiologist is getting a little worried about my coronary artery disease, and then you can look into is there something we missed and can we do something about? I already told you that your LP-little-a test is not something that you can intervene on right now.
Right.
So it will add to your stress, and stress is a major reason why people actually also neglect their cardiovascular risk. But if you can't intervene on it, the knowledge may certainly help you if in the future a drug company finally says we've got data that work and we think it should be applied, right? So yes, you could certainly do that, but I wouldn't do it right now. But let's talk about someone who wasn't on therapy. Let's say, Noor, that you had
Yeah.
walked into your clinic and you were working on it.
Right.
Then I think at that time, it would be worth thinking, let's look at this and say, okay, your cholesterol's up a little, your blood pressure's well controlled, you're a little old, but not so bad. You're in pretty good shape. Are you exercising, eating right? And you go, yep, yep, yep. And then say, all right, well, let's see whether you really need to lower your cholesterol even more. Then you could use a coronary artery calcium as a tiebreaker, right?
Hmm.
Your numbers are not quite there, but as a tiebreaker, can I be safe or not? You could say, let me get a calcium score done.
Right.
I will now also say in the same breath, we still don't have good data on whether we can intervene on calcium score, because calcium score is basically the hardening of the artery with calcium deposition in the arteries, and your CT scan is just picking that up.
Right.
And no one's shown that if you intervene and try and lower that calcium score, that you're going to lower your future heart disease profile. Whereas people have shown that if you lower your cholesterol, LDL cholesterol, right, you do change that. And the only score that is helpful is a calcium score of 0. Anything above 0 says you've got some deposition of calcium in your arteries. And I have patients who come in and say, my score is 10, or my score is 300, or my score is 600, and they panic about the 600. And I tell them, actually, that number is not reflective of how bad you are.
Hmm.
It's just reflective of the fact that you've got disease. So
Right.
it's a binary system, yes or no.
Right.
And the no is 0. You
Hmm.
have 0, then I'm going to say, okay, you don't want to take a statin. You know what? Your cholesterol is a little high, but you don't want to take a statin. I'm okay with that.
Right.
So that's the decision making. But if your cholesterol is high, and even if your coronary arteries calcium score is 2, I'm going to say, hey, I think you should go on a statin, right? And talking about drugs, yeah, we didn't touch on this, but sorry, excuse, um, it, you statins are our base drug for everyone in the world.
Hmm.
They have a huge amount of evidence. Yes, they can cause some side effects, but in people who tolerate them, the science base for showing that they really help prevent future coronary artery events, future stroke events, is really very powerful. And they're very cheap. There is now almost no statin drug that is not generic. So in terms of equity, almost everybody can afford it wherever they are in the world. right? So really, statin drugs are the base, and then newer drugs are going to come out that allow us to become more intensive, or people who can't tolerate statin drugs, then we have other choices, and we can talk about the evidence base for that.
Okay, I'm going to digress a little bit because just a quick question about calcium scores. So
Yep.
if somebody's got a very high calcium score, it really is saying that your coronary arteries are coated with calcium. Is there, I mean, that by itself is not going to cause a cardiac event, is it? It's going to be more plaque rupture. But is there evidence that calcium by itself coating coronary arteries leads to more cardiac events? Or is that just implied?
Yeah, it's just implied. And actually, in your neck of the woods in Dallas, in fact, there's a guy there who came from WashU and he's now working at there. He took these coronary arteries with the calcium and put them under the electron microscope. And if you look at that calcium under the electron microscope, it looks exactly like if you'd taken a biopsy of your bone. It's really woven bone.
Yeah.
And what it is, and what people think, again, the science is still evolving. So things that I say need to be taken with the fact that it may need to be modified in the future. But I think that the deposition of calcium is your body trying to protect itself against the ongoing damage.
Yeah.
Now, does that mean that if you can undo it, that your coronary artery will become better, more pliant? Will they be able to relax and expand when the blood's going through and all that? We don't know that yet, right? But certainly, yes, it's just saying that you've got damage and you've calcified your artery as part of the healing process, right? But it's also saying that you actually had damage, right? So that's the thing that I think is established, that it really is reporting damage. But which way is it going? Is it that your body is healing and protecting it? Because you are quite right that the acute event in myocardial infarction, heart attacks, is plaque rupture. When that endothelium peels over, and before you know it, the platelets bind, and before you know it, a whole clot forms, and before you know it, the artery is blocked. And once your artery is blocked, no more blood further downstream, and then the heart muscle gets damaged, right?
Right.
So that's the acute event. But yeah, you're right. Is it helpful and protective? Or is there going to be an issue? We don't know that yet.
No. All right. Well, I kind of interrupted your train of thought, but we were going to talk more about your paper, new treatments. I've been hearing about PCSK9 inhibitors. So, yeah, I'll let you get back on your train of thought.
Yeah. So we're talking about, so our paper was really to talk about the updates in the lipid management. And prior to our previous one, newer drugs had come out, but the evidence on how they're going to work and what the utility is was developing. So this update was really to just summarize what had happened in the interim and whether we have ways to look at it. So what are these PCSK9 inhibitors? So what is, first of all, PCSK9? And so before you even get into it, and again, this may be a little bit too much for your lay audience, but um, so the way your body is clearing these mayonnaise particles, these lipoprotein particles, is that the liver, which is the main organ that clears your lipoproteins, has receptors on it. And the classical big receptor, the main one, is called the LDL receptor. And as its name suggests, it is taking the LDL cholesterol particle, taking it into the liver, dissociating it, taking the contents out, and then going right back up on the cell surface again to grab more LDL cholesterol. PCSK9, and I'm not going to tell you what the PCSK9 stands for, but it is a protein that the liver makes. And like everything in the body, everything that we do, there's a yin and a yang. So if the receptors are going back out, right, and coming back in and going back out, the receptor recycling, there is a yang that says, hey, every now and again, maybe we need to regulate the LDL receptor. So this PCSK9 protein, which is made by the liver, is actually to regulate how many of these LDL receptors, instead of going right back out, go into the trash can and get recycled themselves, right? And if you take the PCSK9 out of the body and you don't let it work, then what happens is that your receptors keep working even harder, and then your LDL cholesterol comes down. And this concept actually came, this concept came from people who were born with a mutation that didn't allow them to make PCSK9. Right. What did they do? Were they ill? Did they have a problem? Because genetically, they did not make any PCSK9. And it turned out that actually the one thing they had was very low cholesterol levels.
Right.
And of course, they also had a very low risk of developing future cardiovascular events.
Right.
So the drug company said, oh my goodness, what if we took it out in most people? And sure enough, that experiment absolutely worked.
Right.
And then they took it to the clinical trials and they showed that they really lowered cholesterol. And they took it into patients who had heart attacks and they gave it to them in clinical trials. And that was the basis for why the FDA approved these agents. At that time, we only had one way of inhibiting the PCSK9, which is to inject antibodies. So you make a artificial antibody to PCSK9, inject it, your body, the antibody goes in, takes the PCSK9 away, your liver LDL receptors work wonderfully, and your cholesterol drops. They actually turn out to be the most powerful agents. So compared to a statin, for example, the lowering of LDL cholesterol on the PCSK9 is fabulous, absolutely fabulous. And of course, it was initially tested on patients who had genetic reasons for having high levels of LDL cholesterol, right? What we call familial hypercholesterolemia. And they were so effective. That is kind of like where most patients with FH, familial hypercholesterolemia, are probably going to end up on, right?
Right.
Not everybody, but most people are. And then people with secondary heart disease, so they've got heart disease, their cholesterols have improved, but not great. They get on these drugs as well. And our paper was more about saying, now that they're there, are they cost effective? Do they make sense? And the answer is yes, they do make sense. They should be used in the right circumstances. And we're updating our providers to say, here are the circumstances under which you would consider using them. Now, I said two ways. The first way is clearly the antibodies, and two companies make those drugs, and there'll be more, I'm sure, because it's there, the market's there. But the second way is another company said, what if we went to the liver and took the message out of the liver to make the PCSK9 in the first place?
Right.
So they developed a way of doing it, and there are two molecular biology ways of doing it. One is to make something called interfering RNA, so siRNA, right? And the other is to make a short sequence, a short single-stranded DNA sequence called oligonucleotide. So DNA is double-stranded, right? Watson and Crick pair to form the helix. But if you take one part and then you make a complement to a short part of it on the other side, that's the short piece of nucleic acid called oligonucleotide. And if you inject that, but it matches the message
Right.
the liver's making, the message will get degraded because there's mechanisms of doing that. So one of the companies made therapy that targets the message in the PCSK9, and its trade name is Leqvio, Leqvio, but it is an injection that, one, it's not available for patients to give themselves. They have to go to an office to give, but it's given twice a year, and it will also take out the PCSK9 to therefore do the same thing. The other two, the antibodies, the patients can actually take it home, right? So they don't need to go into an office, but they usually give it either every 2 weeks or every month at home. It's like a little pen, almost like a insulin pen, and you use it. And a lot of people tolerate it amazingly well. So those are the newer drugs that came out. And then in a slightly different way, looking at that pathway to try and still help improve how you make your LDL receptors become more efficient. Statins work on inhibiting the cholesterol synthesis in the liver, but by doing that, they upregulate the LDL receptors. So another company came out with a drug called bempedoic acid or Nexletol or Nexlizet, which is a combination medication, to help improve that as well. And again, it has pros and cons, and that's what our update that we are providing to our providers is looking at under what circumstances would you use that medication to help improve people's future risk of cardiovascular disease. So those were the newer agents. And then we talked about some older agents that we think the evidence for using them is not so good. So we summarize that in our paper as well.
Well, I think that was a stunningly good explanation of these points. I really enjoyed listening to that. Um, so I do want to congratulate you on this paper. It's a major piece of work, and I know it's just an incredible amount of energy went into this. So I know you've got to go off to your clinic, but just to close off, what are the two or three things that people should take away from your update?
Number one, that I think that a very old drug that we used to use way back when, called niacin, there's very little evidence now that says that it's going to be as beneficial as people think, and we um, think that it should not probably be used except under some amazingly very rare circumstances. That the evidence for using fish oils, because fish oils both, you can get them over the counter as well as prescriptions, that again, same thing, the widespread use of fish oil for manipulating cardiovascular disease risk is now very limited. So that should hopefully tell people that if they want to save their money on fish oil and do other things, that might be something that they may want to consider. Um, that the statins drugs still remain the mainstay, that we've got newer agents that work, and they will need to have a discussion with their provider about whether they are the people that it's appropriate for and why, and what are the pros and cons of using that, and the cost implications, because most of these drugs are branded, and obviously the cost of using them is going to be a lot more than a very generic, simple copay. Um, and yes, I'm going to reemphasize again. I started at the beginning. I'm going to start and I'm going to end on it too. Lifestyle, lifestyle, lifestyle. You have to manage your stress. You have to sleep well. You have to eat well. You need to at least get some form of exercise, at least 3 to 5 times a week if you can do it. And these are things that you can do without having to resort to pharmacotherapy.
Excellent. Well, that was superb. I'm going to enjoy rewatching this. You've given me a lot of food for thought, and I mean, in a short period of time, you have really um, cleaned up this subject in my mind. So thanks very much, and have a good
All right,
clinic.
thanks. And again, so good to see you again, Noor. And let's not wait so many
Oh,
years to talk again.